Gaurav?
Yes, sir. I would request Aditi to start with the introduction for the program today for the ENT case presentation. Thank you.
Good evening to one and all present here. I would like to welcome all the IMA KSB and IMA MSN members to the ENT case presentation, which is happening for the first time in IMA MSN. I would like to welcome Sumaya Fareen, second year MBBS student of Dr. Ambedkar College, Bengaluru, the presenter of the event. I would like to extend a warm welcome to Dr. Prahalada Sir, Senior Professor and former Head Department of ENT, Basaveshwara Medical College, Chitradurga. I would like to welcome Dr. V.V. Chiniwala Sir, President IMA KSB, Dr. Suriraju V. Sir, Honorable Secretary IMA KSB, and Dr. Narayan Murthy Sir, Chairman Academic and Medical Education Subcommittee. I would like to request Dr. Narayan Murthy Sir to give the welcome speech and take over. Thank you.
Thank you, Aditi and Gaurav. It's my privilege to propose welcome speech on this occasion, our first academic and medical education activity, along with MSN of our team. At first, I welcome Dr. Chinwala VV Sir, President IMA KSP, to this teaching program. Sir, you are here, sir?
Hello.
Yes, sir, you are here, sir. You are welcome, sir.
Yes,
sir. Next, I'll welcome Dr. Suriraju Sir, Secretary IMA KSB, to this teaching program. Also, I welcome Dr. Prahlad Sir, who is well-known ENT surgeon, senior professor, former head of the department, ENT, Basaveshwara Medical College, with whom continuously I am working since 22 years. Also, I am a great admirer of him. Sir, I'm very happy that we are starting this teaching program with you. Thank you, sir. Thank you for accepting in spite of your busy schedule.
I consider this is my honor for me. Yeah. Okay.
Yes, sir. I welcome Dr. Sumaya Fareen. Everyone was telling second year student of MBBS, how can she present? But your presentation definitely you can witness now. I wish Sumaya Fareen good luck and also welcome to this teaching program. She is a student, medico of the second year from B.R. Ambedkar Medical College. To this program, I welcome her to this program. Also, we appreciate her interest for the presentation for this today's academic program. Thanks to all academic committee and medical education committee members, especially K. Subrata Madam and Arun Sir from Navodaya Medical College, and all my team of this academic committee and medical education committee. Thanks for MSN committee members also, especially Gaurav and Aditi and other members who are actively involving in this program. It is just a beginning. Good beginning is half a success. I think today we are going with a great start, and we can see many more such good programs in future. Thanks to all, and especially Madhusudan Karignuru sir, who is always a guiding force to me, and all other IMA members, medicos who are today attending this program. Thank you, one and all, and I welcome one and all.
Yes. I think Gaurav, Sumaya can start now, right?
Over to Gaurav for IMA prayer.
Yeah. That's right.
Aditi.
Thank you so much, Narayan Murthy sir. Now I would like to request Subrata KS ma'am to give the IMA prayer and the flag salutation.
Thank you. May everybody be happy. May everybody be healthy. May everybody be free from pain. May everybody be free from sorrow. May we be the healing cure beyond every greed and lure. Thank you. ಧ್ವಜವಂದನೆ ಕನ್ನಡದಲ್ಲೂ ಇರ್ಲಿ ಅಂತ ಫ್ಲಾಗ್ ಸಲ್ಯೂಟೇಷನ್ ಅನ್ನ ಕನ್ನಡದಲ್ಲಿ ಹೇಳ್ತಾ ಇದ್ದೀನಿ. ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜಕ್ಕೆ ವಂದನೆ ಸಲ್ಲಿಸಲು ಇಲ್ಲಿ ನಿಂತಿದ್ದೇವೆ. ಅದರ ಗೌರವ ಮತ್ತು ವೈಭವವೇ ನಮ್ಮ ಬೆಳಕು ಮತ್ತು ಶಕ್ತಿ, ಮತ್ತು ಅದರ ಪಥವೇ ನಮ್ಮ ಪಥವು. ಈ ರಾಷ್ಟ್ರೀಯ ಸಂಸ್ಥೆಯ ಮಾನ್ಯತೆ ಪಡೆದ ಸದಸ್ಯರಾದ ನಾವು ನಮ್ಮ ಜವಾಬ್ದಾರಿಗಳನ್ನು ಅರಿಯುವ ಮೂಲಕ ಅದಕ್ಕೆ ನಮ್ಮ ನಿಷ್ಠೆಯನ್ನು ತೋರಿಸುವ ಪ್ರತಿಜ್ಞೆ ಮಾಡುತ್ತಿದ್ದೇವೆ. ದೇಶ ಸಮೂಹಗಳ ನಡುವೆ ನಮ್ಮ ರಾಷ್ಟ್ರಧ್ವಜವು ಉನ್ನತ ಮಟ್ಟದಲ್ಲಿ ಹಾರಾಡುವ ಸಲುವಾಗಿ ನಮ್ಮ ಅಧಿಕಾರದಲ್ಲಿರುವ ಎಲ್ಲವನ್ನೂ ಅದಕ್ಕೆ ಸಮರ್ಪಿಸುವ ಪ್ರಮಾಣ ಮಾಡುತ್ತಿದ್ದೇವೆ. ಜೈ ಹಿಂದ್. IMA ಚಿರಾಯುವಾಗಿರಲಿ. ಥ್ಯಾಂಕ್ ಯು ಸರ್.
Aditi, the President IMA KSB, Dr. Chinivalar sir is here.
Yes, sir. Thank you so much, ma'am. Now I would request the State President Chinivalar sir to say a few words. Welcome to the event, sir.
Chinivalar sir, yes.
ಅನ್ಮ್ಯೂಟ್ ಆಗಿದೆಯಲ್ಲ, ಕೇಳ್ತಾ ಇದೆಯಾ?
ಆಗಿದೆ ಸರ್. ವಿಡಿಯೋ
Yes, sir, it is audible, sir.
ವಿಡಿಯೋ ಬರ್ತಾ ಇಲ್ವಲ್ಲ? ವಿಡಿಯೋ ಜಾನ್, ವಿಡಿಯೋ ಬರ್ತಾ ಇಲ್ಲ ಯಾಕೋ?
ಈಗ ನೋಡಿ ಸರ್, ನಾನು ಪ್ರಾಂಪ್ಟ್ ಕೊಟ್ಟೇನಿ.
ಅಷ್ಟೇ.
ಕ್ಯಾಮೆರಾ ಮೇಲೆ, ವಿಡಿಯೋ ಮೇಲೆ. ಸರ್. ಎಸ್ ಸರ್. ಈಗ ಸ್ಟ್ರೈಟ್ ಮಾಡಿ. ಎಸ್ ಸರ್, ಎಸ್ ಸರ್.
ಹಲೋ.
ಎಸ್ ಸರ್, ಮಾತಾಡಿ ಸರ್.
ಎಲ್ಲರಿಗೂ ವಂದನೆಗಳು. ಇಂದಿನ ವೆಬಿನಾರ್ ಅಕಾಡೆಮಿಕ್ ಅಂಡ್ ಮೆಡಿಕಲ್ ಎಜುಕೇಶನ್ ಬಗ್ಗೆ ಡಾಕ್ಟರ್ ನಾರಾಯಣ ಮೂರ್ತಿ ಅವರು ಹಮ್ಮಿಕೊಂಡಿರುವಂತಹ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮ ಬಹಳ ಒಳ್ಳೆಯದು. ಎಸ್ಪೆಷಲಿ ಫಾರ್ ಅಂಡರ್ ಗ್ರಾಜುಯೇಟ್ಸ್ ಅಂಡ್ ಪೋಸ್ಟ್ ಗ್ರಾಜುಯೇಟ್ಸ್, ದೋಸ್ ಹೂ ಆರ್ ಗೋಯಿಂಗ್ ಫಾರ್ ಎಕ್ಸಾಮಿನೇಷನ್ಸ್ ಏನಂತೆಲ್ಲ ಇವರಿಗೆಲ್ಲರಿಗೂ ಒಳ್ಳೆಯ ಒಂದು ಪ್ಲಾಟ್ಫಾರ್ಮ್ ಸಿಕ್ಕಂಗಾಗತ್ತೆ, ವೇದಿಕೆ. ಎಸ್ಪೆಷಲಿ ಹುಡುಗರಿಗೆ, ಅಂಡರ್ ಗ್ರಾಜುಯೇಟ್ಸ್ಗೆ ಒಂದು ಎಕ್ಸಾಮ್ ಫೋಬಿಯಾ ಇರ್ತದೆ. ಎಕ್ಸಾಮ್ ಟೈಮ್ನಲ್ಲಿ ಎಕ್ಸಾಮಿನರ್ಸ್ ಬಂದ ಪ್ರೆಸೆಂಟ್ ಮಾಡುವಂಥದ್ದು, ಅಂಥದ್ದು ಈ ಒಂದು ವೇದಿಕೆಯ ಮೂಲಕ ಮೇಲಿಂದ ಮೇಲೆ ಪ್ರೆಸೆಂಟ್ ಮಾಡ್ಕೊಂತ ಹೋದ್ನಪ್ಪ ಅಂದ್ರೆ ಅವ್ರ ಎಕ್ಸಾಮ್ ಫೋಬಿಯಾ ಬಹಳ ಕಡಿಮೆ ಆಗ್ತದೆ ಅಂತ ಹೇಳಿ ನನ್ನ ಅನಿಸಿಕೆ. ಸೊ ಇದಕ್ಕೆ ಈ ಅಕಾಡೆಮಿಕ್ ಮತ್ತು ಮೆಡಿಕಲ್ ಎಜುಕೇಶನ್ ಇದರಿಂದ ಏನಂತಲ್ಲ ಇಂತಹ ಒಂದು ಪ್ರೋಗ್ರಾಮ್ಗಳು ಆಗಿಂದಾಗೆ ಮೇಲಿಂದ ಮೇಲೆ ನಡೆಯಲಿ ಅಂತ ಹೇಳಿ ನಾನು ಎಲ್ಲರಿಗೂ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಹಾಜರಾದಂಥ ಎಲ್ಲ ವಿದ್ಯಾರ್ಥಿಗಳಿಗೂ ಮತ್ತು ಪ್ರೊಫೆಸರ್ಸು, ಟೀಚರ್ಸ್ಗಳು ಎಲ್ಲರಿಗೂ ನನ್ನ ವಂದನೆಗಳನ್ನು ಮತ್ತು ಸ್ವಾಗತವನ್ನು ಬಯಸ್ತಾ ಇದ್ದೀನಿ. ಹಲೋ.
ಥ್ಯಾಂಕ್ ಯು ಸರ್. ಥ್ಯಾಂಕ್ ಯು ಸರ್. Aditi.
Thank you so much, Chinivalar sir. Sir, now I would request the Secretary Suri Raju sir to say a few words.
Suri Raju sir is not there. We can go.
So we can go ahead with the presentation.
Yes.
Right?
Yes, sir. Directly
Okay.
you can do.
I would like to introduce the presenter of the event today, Sumaya Fareen, second year MBBS student, Ambedkar Medical College, Bengaluru. It is my great pleasure to welcome the case examiner of the day, Dr. Prahalada sir, a senior professor and former head Department of ENT, Basaveshwara Medical College, Chitradurga. Sumaya, you can start your presentation. Thank you so much.
Good evening, one and all.
Yeah. You can share your presentation, ma'am. Sumaya.
Sumaya.
Yes, sir.
Only you and Prahlad sir will be unmuted and all will be muted.
Okay, sir.
Yeah. If anybody has any questions, all the participants, you have equal opportunity to ask questions. If anything, raise your hand or post it in the chat. I think that's the best, to not to disturb the program, to allow smooth conduct of the program. Yeah, please. Go ahead, ma'am. Share your presentation. Yeah, you can go to slideshow. Yeah. Okay.
You're muted. Just unmute and start.
Yeah.
Yes, sir.
Yeah. Slideshow. Yeah. Okay.
This is a case of an 18-year-old female named Fatima, who is a student by occupation and a resident of Neil Sandra, Bangalore,
Mhm.
presented with chief
Why
complaints
did
of
you
right.
why did you take those histories in the beginning, in the first page? These things. Why
Basically,
this is important?
name is required for addressing the patient and
Mhm.
building a rapport between the patient and for
Okay.
documentation purpose.
Mm.
Age is required for ruling out the age related disorders, like certain diseases are more common in certain ages. And coming to sex, again, certain diseases are more common in females and certain diseases are more common in males. Occupation, there are occupational related disorders also. That's the reason we take all these particulars and address because of the endemic diseases which we
Yeah.
see.
Yeah.
Example can be rhinosporidium.
Yeah, yeah. Excellent. And also, this will indicate their socio-economic status also is very important because
Yes.
this is a case of chronic suppurative otitis media, which is likely to be more common in low socio-economic status, people living in low socio-economic status. Yeah, excellent, Ma. Go ahead. Next slide.
Presented with chief complaints of right ear pain since childhood and complaints of decreased hearing in the right ear since childhood.
Yes, go back. See, as a student, as medical student and medical doctors, the moment we take chief complaints, our brain should start work like a computer. At this stage itself, we should have a list of differential diagnosis. Okay, so what differential diagnosis you would give yourself at this stage? Patient is having right ear pain since childhood.
I would see if the pain is related to the ear, or is it because of any referred otalgia, like any ear tooth ache can also cause tooth cavity
Yeah,
can
okay,
cause
related to
ear
ear,
pain.
primary pain from ear. What differential diagnosis will you have in your mind?
Whether it is any external ear complication or in middle ear complication.
Yeah, we
Furunculosis
have to
can also be
classify. Yeah, nice. You have to classify whether either
it is
the pain can
external
be
or
from external ear, like you said, the furunculosis, otitis externa, foreign body in the ear, and so many things, and also problems in the mid ear, like otitis media and things like that. So we should have a list of differential diagnosis at this stage itself. Okay, so when we take history of presenting illness, we are going to analyze one by one, and we are going to rule them out, isn't it? Same thing.
yes.
Decreased hearing also, we should have a list of differential diagnosis, and based on that, we are going to rule out which may not be there, which may be there with the history, with the further history and clinical examination. Okay, this is the methodology we should follow. When this was designed, the what book, which book we refer for all these things is the Bible for clinical examination is Hutchinson. Okay, Hutchinson's clinical medicine. So the entire system of this modern medicine has been so well crafted, systematically arranged, so that we arrive at particular diagnosis at the end of the examination. Chief complaints, history of presenting illness, family history, and so many other things. Then the general physical examination, systemic examination, and specific loco-regional examination. That this thing. Okay. Yeah, this is the system we follow always. Yeah, go on next.
Okay.
Hmm.
History of presenting illness. Patient was apparently all well 17 years back. She had
Mhm.
an episode of ear discharge at the age of 1. Later on, she developed right ear pain, which was insidious in onset, moderate in amount, intermittent in nature, and mucopurulent type, gradually progressive and throbbing type. Pain aggravates on exposure to cold and relieved on taking medications. Complaints of decreased hearing in the right ear. Patient finds it difficult to hear whispers and phone calls on the right side, associated with ringing sensation. No history of vertigo and facial asymmetry. Patient has no history of nasal discharge, nasal block, sneezing and snoring. No history of throat pain, pain during swallowing.
Yeah, we'll stay on this slide. This is a very important history you have taken. I really appreciate you for you to, come forward, volunteer yourself to present this case. That's a wonderful job. Many people do have, many students hesitate actually nowadays. Many students, I have noticed some of our students don't even enter the clinical postings and they don't get into the ward, but you've done a good job. Okay. See, now you have presented this in a paragraph. Okay. each word is important and each word should be able to give us an indication what may be the exact cause. Okay. So you said she had an episode of ear discharge at the age
Ear
of
discharge.
1 year. Okay. At the same time, you also said later on developed right ear pain, which was insidious since onset. Okay.
Yes.
So what do you think that may have happened that time?
First,
Though it
she
is very old history, 17-year-old history. What may have happened that time?
the patient was actually very small at that time, so
Yeah.
might be the patient's parents might have ignored the ear discharge, which later
Yeah.
on developed the pain when she was 18 years,
Okay.
and
See,
that
probably what has
gradually
happened is
progressed towards the
probably child had an incidence of acute suppurative otitis media, which was
yes,
ignored and was not well treated. So it continued as chronic suppurative otitis media.
non-secretive
Okay.
autism.
Yeah, yeah. And also you gave another this thing that is intermittent in nature and mucopurulent type.
Mucopurulent.
So why this type of discharge is very important? Mucopurulent type. Why did you take that?
In chronic suppurative otitis media, that is the safe type, usually the discharge is mucoid. Later on, when it gets infected,
Yes.
it becomes mucopurulent.
Yeah.
Um,
What are the other types of discharges you know of that can occur?
Mucoid, purulent,
Hmm.
mucopurulent, watery discharge, or blood stain discharge can be seen. Blood
Okay.
stain discharge can be seen because of
Yeah.
any trauma, or it can be
Okay.
because of any hidden malignancy.
Mm-hmm.
And also in unsafe type of CSOM, we see
Yes.
blood stain discharge.
Yes.
Um, then watery
And
discharge, that is the CS of autoria, can suggest us that there is any intracranial complications or any fracture
Mhm.
of the skull bone.
Okay, excellent. So next, why did you take history of vertigo and facial asymmetry in this patient?
Uh, I basically the negative history is taken out to rule out the complications in the particular case. Here, I just took the history of vertigo and facial asymmetry because vertigo might suggest that there is some intracranial complication and
Mhm.
inner ear is involved, which might be the
Yeah,
complication of CSOM, that is
yeah,
labyrinthitis.
yeah, excellent. Okay, you thought of those complications also. Okay. And why did
Yes.
you take history of nasal discharge, nasal block, sneezing, and snoring, these things?
Um, Whenever we take the ear history, we are supposed to even ask about the nasal and the throat history, because
Mhm.
any upper respiratory tract infection can also get transmitted to the ear through the eustachian tube.
Okay.
Yes.
Fantastic, excellent. And also the adenoid hypertrophy and other sinonasal
Adenoid
conditions,
tonsils can
they
also.
all can cause eustachian tube obstruction. Okay. Eustachian tube pathology, then give rise to otitis media. Excellent. Okay. So you have ruled out these potential complications and potential this thing, inciting causes. That's excellent job. Okay, next.
Past history: patient has no history of tuberculosis, no history of systemic hypertension, no history of diabetes mellitus, no history of bronchial asthma, no history of epilepsy or any other chronic disease.
Okay, next.
Personal history: the patient consumes a mixed diet, appetite is good, sleep is adequate, bowel and
Mhm.
bladder movements are regular. Patient
Mhm.
has no history of drug abuse, no history of alcohol and tobacco intake.
Okay, right.
Family history: no significant family history, no similar complaints among the family members.
Yeah, why this is important in this specific patient?
Because there are consanguineous marriages can lead to sensory neural hearing loss, which is genetic,
Mhm.
and
If it's
autosomal,
patient from low socioeconomic status, even the other siblings may have similar kind of problems. That also we have to keep in mind. And I
or
think
it can be.
one important history you missed in this, that is patient treatment history or drug history. Did patient receive any treatment earlier? Very important, whether adequately treated, not treated. That also we have to take, okay? And also if patient has undergone any surgery or anything for the similar problem, that also we need to find out, okay? Some of this history, sometimes patient may not be knowing because patient started having this problem during childhood, that we may have to elicit this history from parents. Okay, this is also
Yes.
very important. Yeah, go on next.
Coming to general physical examination, patient is an 18-year-old female who is moderately built and moderately nourished. Patient
Mhm.
is well oriented to time, place, and person. No signs of pallor, icterus, clubbing, cyanosis, lymphadenopathy, and edema.
Yeah, we'll stay on this slide for some time. Okay. Okay, this is fine. Patient is 18-year-old, moderately built and moderately nourished. Okay. Why it is important to know that she is oriented to time, place, and person in this specific case?
Uh, Again, sir, it can
Hmm.
cause any intracranial complications if there is any
Yes. Yes.
abscess.
Yeah, yeah. Lot of intracranial complications happen. Can you enumerate what intracranial complications the UG, what complications you learned about in CSOM cases?
Um, Petrositis.
Yeah,
Um,
petositis can occur. It is still temporal classification, this thing, but it can have intracranial symptoms. Okay. Petositis,
Cerebellar abscess, subdural
cerebral
abscess,
abscess, subdural abscess,
extradural
excellent.
abscesses,
Extradural
meningitis.
abscess, meningitis. Yes, meningitis is important. Then what else? There's one more
Um,
condition, that is lateral sinus thrombosis. Okay.
yeah,
So all
lateral.
these things can occur in this patient where all this, patient orientation to time, place, and person can be altered. If patient has meningitis, what do you expect? What other things you notice on general physical examination?
Meningitis. I
Okay,
actually
you
don't
may
know.
not have done the internal medicine posting. That's okay, fine. But the next things which are there, the pallor, icterus, clubbing, and cyanosis, lymphadenopathy, and edema. Are these things important in this specific case?
Uh, it is important, so.
Yeah, yeah. How, in what way?
Um, in hypertensive patients, there is common episodes of epistaxis, which may lead to
Mhm.
anemia.
Mhm.
Again, if the tympanic membrane is having perforations, and if we need to go for surgery, tympanoplasty, we need to do the blood investigations, which will also need the hemoglobin level, and anemia should be considered in that.
Yeah, okay. That's also fine.
Also,
But also pallor, general anemia means again that may indicate low socioeconomic status. Which can again lead to recurrent upper respiratory tract infection,
infection.
and also malnutrition is very important. Majority of the children who present with CSOM, chronic suppurative otitis media, they have malnutrition. Okay, that can again predispose them for CSOM malnutrition, and also icterus may not be very important in this thing, whereas clubbing, cyanosis, lymphadenopathy, and edema, we have to look for them. Okay. Lymphadenopathy specifically, if any abscess or anything happens, complications of CSOM like, Citellis abscess, Bisol's abscess, and all those occurs in that relationship, it can be there. Okay. So we have to look for all these things. Okay. You've done a good job. Okay. Go on to the next.
Vitals of the patient. BP
Mhm.
was 120 by 70 mm of Hg.
Mhm.
Temperature was afebrile. Pulse
Mhm.
rate was 80 beats per minute. Respiratory rate was 16 cycles per minute.
Okay.
Saturation is 98% at room air.
Why knowing this vitals? We'll go back to that slide. Why knowing vitals is very important in this specific case. It is
Uh,
just a simple CSOM. Hmm?
because sir, because of the infections, there are chances that the patient can develop fever, headache,
Yes.
and
Yeah.
um,
If patient has fever, then patient pulse rate may go up, isn't it? Patient
yes,
may tachycardia. Okay. If patient have complications like intracranial complication, other complications can also have an impact on respiratory rate as well as saturation, isn't it? Okay.
yes.
Yeah. Okay. That's good job. Okay. Did you examine all this yourself in this patient?
A few I took help from the PGs, sir.
Okay, okay. But you should make it a point to examine this yourself. Okay.
Yes,
So
sir.
pulse rate, see, you written pulse rate, but is it complete statement what you have written? Is it enough?
No, sir. Rate, rhythm, volume, and
Yes. Why you didn't do that? So you should have done that, isn't it?
yes.
See, I seen like nowadays, patient, students don't examine the pulses and all these things, vital examination themselves personally. They give an excuse saying either BP apparatus was not available, thermometer was not available, or something like that. But see, pulse is something which is easily, you just need your fingers, isn't it?
Yes, sir.
Yeah, and also based on the just pulse itself, we can diagnose many diseases, mainly the cardiovascular system diseases, isn't it? There's so many based on the rhythm and change in the rhythm and all that. And to understand that rhythm, different rhythms, different beats, different types of pulses, like bigeminy, trigeminy, so many things are there. Okay. For that, if you want to really master those, you would have seen at least, pulses of about 10,000 patients. That's what I heard. I read a book. If you want to master how to read a pulse, you have to see 10,000 patients. Okay. So that means every patient you come across, you must feel the pulse. Okay. Make it a point next time. Don't rely on the other gadgets, okay, to make a diagnosis and or investigations to make diagnosis. Use your this clinical skills. See, I always emphasize my students that is these clinical examinations is tools of our trade. Okay, every profession has a tools of trade, right?
Yes, sir.
You've seen a carpenter. What does he carry? He carries some equipment,
Yes.
right? You've seen
Yes, sir.
engineering students. What do they carry? They carry the draft and things like that. Okay. Like that, we have to carry our clinical examination equipment. I will come to that, this thing subsequently, that clinical kit. Okay. And we have to examine ourselves, all these patients look into that. Okay. Yeah. If you want to be a good doctor, that is an essential skill we need to develop. Okay. Go on to the next. Yeah. Yeah.
Systemic examination.
Mhm.
Respiratory system. Normal vesicular breath sounds heard. Per abdomen. Soft
Mhm.
and non-tender. Bowel sounds heard. Cardiovascular system. S1, S2 heard. No
Mhm.
murmurs. Neurological examination. Normal
Mhm.
higher mental functions. No focal neurological deficit seen.
Okay. Go back. Go back.
ENT examination.
No, go back, go back. Is a neurological examination complete?
Uh, no, sir, because we have to do the sensory examination and
Yes. Why that was not done? You should have done that. Okay. So what is the system we follow neurological examination?
system.
Hmm.
We do the sensory examination. We do
First,
the
again, we have to look at whether patient is oriented to time, place, and
mind
person.
presentation.
Okay. That is the first thing. Second thing, next thing, what do we do? What do we examine next first? Next thing.
If the patient is speaking properly and the gait of the patient.
Okay. That's all you would have seen. Okay. When we check for the time, place, and person, we check all that. Then what we do, we next go for the cranial nerves, isn't it?
Yes, sir.
First, we do the cranial examination, then we do the motor system examination, then sensory examination. Then lastly, what we do?
One second.
Cerebellar function test we do,
Yes,
isn't
sir.
it? Why I'm emphasizing this is this is the system of neurological examination we have to follow. Okay. And this
Yes,
is
sir.
very important if we are doing a ear examination, for ENT examination for that matter. Okay. Because you said in the beginning, you wonderfully answered saying patient may have intracranial complications, isn't it?
Yes, sir.
So unless you do the systematic CNS examination, how do you know that patient doesn't have any CNS complications, right?
Yes, sir.
One is we are supposed to know whether it's oriented time, place, and person, and what are the cranial nerves that can get affected in the CNS complications of chronic suppurative otitis media.
Facial nerve palsy can occur,
Yeah, that is the commonest that
and
can get involved. Okay,
abducent
and
nerve
next
can
commonest,
be
which now
abducent nerve,
before that abducent now, which is the next common nerve get affected in the CSOM.
trigeminal nerve,
No, nerve within the ear.
um,
Which is the cranial nerve which is within the ear.
auriculotemporal.
No, that's not, that's a sensory nerve. Vestibulocochlear nerve,
Yes.
the hearing nerve. Okay, that is the next. Okay, that can vestibulocochlear nerve can get affected in some CSMs, resulting into complete sensory neural deafness or partial sensory deafness. There may be, we say sometimes mixed hearing loss, this thing and all. Okay, and next comes in patient has a condition. You said Petrus sapicitis. What happens in Petrus sapicitis?
Yeah, sir. There is Gradini-Ghost syndrome.
Gradenigo syndrome. Excellent. Gradenigo syndrome can occur. Okay.
Patient will have the
Yeah.
retroorbital pain
Yes.
because of the damage to the trigeminal ganglion.
Okay.
And patient will have diplopia
Mhm.
because of the damage to the abducent nerve.
Yes.
And otalgia.
Yeah. So Gradenigo syndrome, patient can have lateral rectus palsy, which leads to, okay, that is diplopia, what you said is
Yes,
this
sir.
thing. So we have to examine. So which other nerve can get involved? That is trigeminal nerve, isn't it?
Yes, sir.
So, and also in subsequently, if there is increased intracranial pressure, okay, then other nerves can also get affected. Okay. So suppose if we want to check increased raised intracranial pressure, what do we do? How do you to find out whether there is raised intracranial pressure?
We do the Seeger's pneumatic speculum and check for any nystagmus in the eyes. And
More than nystagmus, raised ICT, raised intracranial tension. How to examine?
for
We send to
pressing.
ophthalmologist. If you have, I was trained in PGI Chandigarh. So there, even though I'm an ENT surgeon, they taught us how to use a fundoscopic examination. Okay. Otherwise, we refer to the ophthalmologist. Do a fundoscopy. What do we see in the fundoscopy?
We see the
We look for
lens.
not length,
Very sure.
raised intracranial pressure. So go and read about it. I will tell you at the end of this thing. Okay. Yeah. Okay. So that is, we do fundoscopic examination to see whether raised intracranial tension. Okay. That also we see. If there is involvement of sigmoid sinus, that is lateral sinus thrombosis, then there may be lower cranial nerve involvement also. The lower cranial nerve means 9, 10, 11, 12. Okay. What are those nerves? Glossopharyngeal, vagus,
Vestibular.
accessory, and hypoglossal nerves. Okay. So we have to examine those nerves also. Okay. So unless we examine complete, thoroughly neurological examination, ear examination is not complete. Okay. That's why why I'm telling you this is to emphasize how in system of medicine, one area is related to other area. Okay. Everything is interrelated. Okay. Finally, if there is a posterior fossa abscess, we call cerebellar abscess, then what we have to do? Cerebellar examination, isn't it? We have to
Yes, sir.
look for the gait and do the cerebellar function test. Okay.
Yes.
Yeah.
Yes, sir.
So this thing, what cerebellar function test you know of?
Ataxia, Romberg's test.
Mhm.
Then we ask the patient to stand still by closing the eyes, and if there is any fluctuation, then there is we tell that the patient is a cerebellum is
Okay.
affected, and
Okay.
ask the patient to walk in such a way that the patient one leg's
Okay.
heel touches the other leg's toe. I just forgot the
The
word.
U, yeah, yeah, yeah. You know the finger nose test.
Yeah, sir, finger nose test.
Okay.
And
Have you heard about the terminology called dysdiadokinesis?
yeah, sir, this
Yeah, yeah. Okay. So go so read all those things in detail, okay? And also I'm emphasizing this to all the students who are also here. You know, that is how you should be thorough with examination system, okay? Your examination should be thorough and complete. Let me tell you something. I go as an examiner, as a PG examiner, as well as UG examiner. I also go as a DNP examiner. If a student tells wrong diagnosis, I don't get upset. But if a student has not done thorough examination, I get upset. There should not be any laziness in examining the patient thoroughly.
Yes.
Okay. That is, secret of our trade. Okay. Go on next.
ENT examination of the ear. The preauricular area on the right ear was normal. On the left ear was also normal. Pinna, the size was normal on both the ears. Postauricular area was normal in both the ears. External auditory canal appeared to be normal. Tympanic membrane. In the right ear, a single medium central perforation which was present in the anterior inferior quadrant, having smooth edges. cone of light was absent in the right ear. In the left ear, the tympanic membrane was intact and cone of light was present. Facial nerve was intact on both the side.
Okay. Okay. What are the different parts of the tympanic membrane, you know?
There's pars tensa and pars
Mm-hmm.
pars tensa and
Okay.
pars.
So what are the differences? How they differ pars tensa and pars flaccida, isn't it?
Yes, sir.
The other big this thing is pars flaccida, right?
Tympanic
Okay.
membrane is oval in shape, and it is it is attached to the um, it is attached in the form of an
Yeah.
annulus.
Yeah.
Um,
There's an
but
anatomical difference, you know, structural difference mainly, histological
yes, sir.
difference. Okay. The pars
And
tensa has 3 layers. Okay. Pars flaccida has 2 layers. There is no middle connective tissue layer in the pars flaccida. Okay. Pars tensa has 3 layers: outer epithelial layer, and inner mucosal layer, and in the central connective tissue. Pars flaccida doesn't have it. Okay. So we should know the such differences also. Okay. So why did you examine these areas, preauricular area, postauricular area, and all
uh,
that?
to see whether if there is any preauricular sinus present,
Mm-hmm.
the size of the pinna, if there is a microtia or macrotia or
Mm-hmm.
anotia,
Mm-hmm.
post-auricular area for any scars or any deep vein thrombosis which is present in the
Yeah,
mastoid
yeah.
emissary veins.
Yes, yes.
Um,
What is that sign known as? Do you know the sign? There is a sign named after that. Okay. Go and refer to that. It's called Gresinger's sign. Okay.
yes.
There is a sign if that this thing is there. Okay. Mastoid emissary vein thrombophlebitis is there. Okay.
Okay.
Yeah, very important. Anyway, no, I would have become yeah, angry if a PG didn't answer, but I wouldn't be angry on you. Okay, no problem. If you know that, it's a good thing. Post-auricular area mainly very important, mainly because there may be post-aural abscess. Okay, a subperiosteal abscess, anything, one of the complications of CSOM. And also extrinsic canal examination, we also have to look for any discharge. What is
Discharge.
the characteristic of discharge? Okay. We have to note different characteristic of the discharge. Okay. The color of the discharge, consistency of the discharge. And also, if possible, we have to check for the foul smelling discharge.
Yes, sir.
Okay. In which condition foul smelling discharge can occur?
In unsafe variety of the CSOM, there is foul smelling discharge,
Yeah. Yeah.
whereas in safe CSOM, there is no foul smelling
No
discharge.
foul smelling discharge. Okay. Fantastic. Okay, ma'am. Go on next.
Tuning fork test. Rene's test with 256 hertz. In the right ear, bone conduction was greater than air conduction. With 512 hertz, bone conduction was greater than air conduction. In 1024 hertz, air conduction was greater than bone conduction. In the left
Okay.
ear, with 256 hertz, air conduction was better than bone conduction. With the 512 hertz, it was air conduction better than bone conduction. And 1024 hertz, air conduction was better than bone conduction in the left ear. Weber's test
Okay.
was lateralized to the right ear. Absolute bone conduction was same as the examiner in both the ears. Vestibular function test, nystagmus, no spontaneous nystagmus was observed, and fistula test was negative in both the ears.
Okay. How did you perform fistula test?
Fistula test is usually done with the Siegel's pneumatic speculum, but
Pneumatic speculum.
I did
Yes.
with the by pressing the tragus in alternatively.
Yeah, alternately pressing the tragus in order to increase the pressure in the extrinsic canal. Okay, that's good. That's a good enough technique. Okay, but if you have a Spiegel speculum, you use it. So why do we do fistula test?
We to see if there is any complications again. That is in perillum fistula or
Yeah, fistula also. And this is a
Meniere's
CSOM
disease.
case. Yeah, we want to see any inner ear fistula. Okay, mainly in CSOM cases, we look for any erosion of the semicircular canals. Okay, and rarely cochlear. Semicircular canals mainly lateral semicircular canal sometimes. There may be erosion or destruction of the semicircular canal if it is a cholesteatoma, okay, where the fistula test is positive. Okay, if you have done that, it's a fantastic thing, very good thing. Okay. And other thing is, why did you test with 324, not just one?
To grade the degree of hearing loss, sir. If
So how do we grade it?
If Renius is negative with 256 hertz and positive with 512 and 1024 hertz, then it is mild hearing loss. If it is negative with 256 hertz and 512 hertz, it is moderate hearing loss. And if it is negative with all the three, then it is severe high hearing loss, sir.
Yeah. So how much? How much is in terms of
20
decibels? How much is mild? How much is moderate? How much is severe?
Mild is 20 to 30 decibels, moderate is 30 to 45 decibels, and 45 to 60 is high hearing loss.
Fantastic. That's a great job you've done. This thing. Okay, ma. Go on to the next this thing.
Examination of the nose. External appearance is normal. Vestibular examination, the tip raising test. Vestibule on both the side appears to be normal. The septum was centrally placed. Lateral wall of
Okay.
the nose was normal on both in both the nostrils. Floor of the nose was normal. Mucosa was normal in both the nostrils. Posterior rhinoscopy was performed. And that's we see the posterior part of the nasal septum, which was normal, and the middle and inferior turbinates were appeared to be normal. There was no hypertrophy.
Okay.
The eustachian tube was patent.
Okay. So you did the posterior endoscopy?
I couldn't perform, sir.
Yeah. So you should mention that. Okay.
Yes.
If you couldn't perform, you should mention that. But next time, go learn how to do a posterior endoscopy. Okay. When you have an ENT posting, you ask your teacher, sir, I want to learn how to do a posterior endoscopy. Teach me, and you must learn that. Okay.
Yes, sir.
I couldn't perform. That shouldn't happen. That's okay for the examination, if are okay. But this is for yourself, isn't it? For you to learn. Okay. So you should know how to perform a posterior. Otherwise, you will miss an
Told to
important finding
perform,
there.
sir,
Okay.
but
Yeah. Next. Go on to the next.
functional tests. Sensation of smell was normal in the right and left nostril. Cold spatula test, equal fogging on both the sides. Cotton wool's test, equal movement on both the sides. Cottl's test was negative. Paranasal sinuses, frontal sinus bilateral non-tender. Ethmoidal sinus bilateral non-tender. Maxillary
Okay.
sinus is bilateral non-tender.
Okay. So what is Cottle test? Why do we do that?
Cottl's test is basically moving the cheek of the patient towards the other side and see if there is any easiness in breathing.
Breathing.
Uh,
Yeah.
if the
Mainly, this is done in mainly, when nasal wall collapse or something, nasal obstruction due to nasal wall collapse or caudal septal dislocation there may be nasal obstruction, okay? And you do this test, then Yeah, okay? Then the breathing becomes easy. Okay, ma'am, perfect. Go on to the next slide.
examination of the oral cavity, mouth opening was adequate, lips, teeth, and gums were normal, gingivolabial and gingivobuccal sulcus was normal, buccal mucosa was normal, anterior two-third of the tongue was normal, hard palate was normal, floor of the mouth was normal, retromolar trigone was normal.
Yeah, mouth opening is adequate means how much is adequate?
Adequate.
Yeah. Okay, mouth opening. How do we measure the mouth opening? In terms of what? There are two measurements in terms of scale, that is in centimeters. We also measure in terms of the fingers. How many fingers he can, he can take in his mouth? 1 finger, 2 finger, 3 finger, 4 finger. It should be at least 4 finger, okay? Yeah, because nowadays we have a lot of patients eating this gutka, whatever, pan and other things, So they come with a lot of trismus. That's our measure. Okay, you should know how much is a mouth opening. Mouth opening is an important factor, okay, for us as well as anesthesiologists, and also in conditions of snoring and obstructive sleep apnea syndrome, we look for the mouth opening and other things. Okay, next, yeah. Next slide.
Oropharynx, soft palate was normal, uvula was central, Anterior
Okay.
pillar normal on both the sides. Tonsilla fossa. Bilateral tonsils are normal. Posterior
Okay.
pillar normal on both the sides. Posterior pharyngeal wall was clear.
Mhm. Okay, fine,
Move to the
great.
next.
Mhm. What do you expected to see in posterior pharyngeal wall? Why did you say clear?
If there
What do you
is
mean clear?
the hypertrophy of the tonsils, then the posterior pharyngeal wall won't be clear,
Yeah,
and
may
you
not
won't
be
be
seen.
able
And
to see.
also, when we look at posterior pharyngeal wall, is there any granular pharyngitis? Okay. And also, we look for any postnasal discharge, isn't it?
Yes,
Okay.
yes, sir.
Yeah.
Indirect laryngoscopy. Base
Mhm.
of the tongue was normal.
Mhm.
Epiglottis was normal. Tracheal
Mhm.
rings normal. Piriform fossa normal.
Mhm. Okay.
Neck examination. Trachea appears to be central. Laryngeal crepitus present. No presence of any scars, sinus swellings. No palpable cervical lymph nodes.
Yeah.
Summary. The
Mhm.
patient is an 18-year-old female presented with right ear pain since childhood and decreased hearing in the right ear since childhood. The patient has no history of diabetes mellitus or tuberculosis. Examination reveals the presence of a medium sized perforation in the anteroinferior quadrant in the right ear.
Yeah.
Provisional diagnosis.
Mhm.
Right ear chronic suppurative otitis media, mucosal in inactive state with moderate conductive hearing loss in the right ear without intracranial or extracranial complications or upper respiratory tract infections.
Okay. What is the one complication this patient has?
Um, the patient had tinnitus, sir.
Okay. Patient has tinnitus. Did you mention about that in the beginning?
Yes, sir.
Okay. And what else?
Mm,
Hearing
Moderate
loss.
conductive hearing
Yeah,
loss.
hearing loss is a complication. Okay. That we
Yes.
should, yeah, you mentioned that this thing. Okay. So now, how would you like to evaluate this patient? What treatment you would advise?
First, I would like to see the patient in
Mm.
microscopic examination if
Yes.
any
Very good.
pus is
Excellent. Excellent.
present.
Yeah. Mm.
Then I would suggest that the patient should be taking some antibiotics if the pain is more, so that the infection reduces, and
Mhm.
oral toileting should be done,
Mhm.
and prevent the ear from exposing to water, and
Mm.
after doing the blood investigations, we would do the tympanoplasty in order to cover the perforation.
Okay. What do you mean by oral toilet?
Oral toileting, there is that we need to clean the ear. First there is wet mopping, dry mopping, clean out the pus and the discharge which will be present in the ear, and then wet cleaning, clean it with a saline to provide a sterile area, and there
Mhm.
is suction to remove if any
Yeah.
infections.
Either we do the mopping, okay, or we do the suction, okay. That is
Yes, sir.
how it's very important. Okay, it's one of the best form of treatment for all the chronic suppurative otitis media patient discharging ears. Okay,
Yes,
okay,
sir.
okay. You're done mopping and you're given is antibiotic alone. You want to give some analgesics and other things,
Antibiotic and
decongestants.
yeah,
Yeah, yeah.
analgesics and
What are the
decongestants and
usual
ear
the common
drops.
positive organisms in the otitis media usually?
Staphylococcus aureus and streptococcus in the adults, and whereas Haemophilus influenza in children.
Children, yes. Mhm.
Yes, sir.
What are the organisms?
Uh,
Suppose patient
fung-
has
fungus.
fungal infection can occur.
Yes.
Bacteria, other bacteria. Some
Aspergillus.
patients say you notice green color discharge.
There was one case which I saw, sir. The
Mm.
Aspergillus niger was present in the ear, and they
Oh,
did the suction and removed it.
okay. No, I
Yes.
said bacterial infection, green color discharge. In which condition? Is it which bacteria?
Um,
Characteristic. Okay. That's Pseudomonas aeruginosa. Okay.
okay.
Yeah. So usually we give. We should also see this. What is the color of the discharge? Okay. It can
Yes.
be sometimes blue color discharge. Maybe
It
there.
can be blood
So,
stained.
Blood sign is okay. You told me about the differential diagnosis. That was nice of you. Also, blue color discharge can occur in proteus infection, and also some patients use gentian violet as a treatment. Then you will see the blue color coming out of their ears. Okay, yeah, okay. After you have examined under the microscope and you clean the ear and everything, given the treatment. Okay, yeah, either he is responding to the treatment, either she is responding to the treatment and the perforation is healing. If it is not healing, what you will do next?
If it is not healing, then we would do mastoidectomy.
Hmm. Why mastectomy? This is only a perforation, isn't it?
If the pain
What is the
aggravates,
procedure we do for to close the perforation of the tympan?
tympanoplasty.
We do either laryngoplasty or tympanoplasty. Okay, there are different entities. Okay, yeah, laryngoplasty or tympanoplasty. Along with tympanoplasty, sometimes we may have to do mastectomy also in certain conditions. Anyway, I will not dig deeper into it for you. Okay. Next, is there any slide after this?
Oh yes, that plan of
Okay.
action.
Yeah, topical antibiotics and oral toileting. And you know what's the definition of tympanoplasty?
Yes, sir. Taking a graft from the person's
Mhm.
body and doing an overlay or an underlay
Yeah. Okay.
treatment.
That is the technique. The technique is different. The main definition is the tympanoplasty means we have to achieve three objectives. Okay. One is eradication of the disease, reconstruction of the tympanic membrane, and also reconstruction of the patient's hearing mechanism. Okay.
Yes.
So that is called tympanoplasty. Whereas laryngoplasty, we just do closure of the perforation. Okay. Yeah, in tympanoplasty, we also have to eradicate the mid-ear
Disease.
disease and reconstruct the tympanic membrane. You should go through these definitions, you should be very well aware of. Okay. And
Yes, sir.
also, yeah, you should know that. And in order to eradicate the mid-ear disease, sometimes we do mastectomy also. Okay.
Yes.
Yeah, either cortical mastectomy, modified radical mastectomy if it is cholesteatoma disease. Okay. Any slide after this?
No, sir.
That's all now. Okay, you've done a great job, but I'll tell you one thing I would like to emphasize you all students. That is, you should be thorough in your history and clinical examination. There is no excuse at all. So next time onwards, do thorough examination yourself and don't miss any examination part. Okay, that will give clue to the appropriate diagnosis, each and everything. I'll tell you, 95% of the diseases can be diagnosed with history and proper examination alone. We need investigations, advanced level investigations, maybe only 5 to 10% of the patients. Okay. So
Yes.
we should try to do that because majority of our patients, they come from low socioeconomic status, they are poor. Okay. Many of them can't afford higher end investigations. So if we can treat them, we get more patients, isn't it? Our
Yes, sir.
patients are our advocates. Okay. With minimum expenses, if you can treat the patients, they will bring more patients to you. Okay. That is a secret of our success in medical career. Okay. Yeah.
Okay.
Okay. I think you have done a great job. I congratulate you for this, for being brave and coming forward to present this case, and that's highly appreciative of you. I hope that this thing, President Sir, Secretary Sir, and Dr. Narayan Murthy, the Chairman of the Academic Committee, sir, I think you should send a certificate to her from your end, sir. E-certificate or something. Narayan Murthy, sir, are you there?
Sir, yes, sir. Sir, we will send, sir. Immediately
Yeah.
after the session,
Okay.
we will send.
Yes, yes. Okay. Yeah, somebody can do the closure and this thing, conclusion and vote of thanks. Yeah. Okay.
Yes, sir. Thank you so much, Dr. Talaga and Sumaya, for this
Yeah.
enriching experience. I would now like to open the chats to any questions you may have. So, if
Yes.
anyone has any questions, please raise your hand and we'll unmute you, or you can type the questions in the chat box.
Any questions? It's questions not just not for Sumaya, it's for me also. Students, if you have any queries, you feel free to ask. Okay. You can unmute and ask question, or you can type in the chat box also. Yeah. Looks like no questions. Yeah.
Yes, sir.
Good job.
Now I'd like to invite Dr. Suriraju sir to say a few words. Thank you.
Yeah, I forgot. Sumaya, we do fundoscopy examination to check papilledema,
Yes, sir.
to rule out dry density. Okay. Yeah.
Okay.
Read about all these
I'll
things.
read.
Suriraju sir, are you able to unmute?
Sir is not there, Aditi. I think you can go ahead and next
Yeah.
closing remarks from Narayan sir and vote of thanks by Subrata madam.
Okay, I would like to ask Narendra Murthy sir to say a few words.
Just check Arun sir is there or not. Arun sir? Arun sir?
No, sir. No, sir.
Okay.
By
I
is not there.
Hello.
Hello, Arun sir is there?
Hello.
Hello. Yes,
President,
sir.
sir. President, sir. Yes, sir.
Hello.
Yes, sir. Yes, sir. Please, sir.
Narayan Murthy.
Yes, sir. Yes, sir.
It is an excellent presentation by an undergraduate.
Yes, sir.
Yeah.
And wonderful teaching by the Professor Dr. Prahlad also.
Thank you, sir. Thank you very much. Yeah.
So, Dr. Narayan Murthy, keep on such this one programs in future also, giving importance to all the subjects.
Yes, sir. Yes, sir. Surely, sir. Under your guidance and able leadership, we will conduct more programs this year, sir.
Congratulations to all the participants.
Yes,
to
sir.
Sumaya, Dr. Prahlad, and also you and committee members.
Yes, sir.
Okay, sir.
Thank you, sir.
Yes. Thank you. Thank you.
Thank you. Just as a formality. Thanks to all, especially President Chinalwar sir, Suriraju sir, and presenter Sumaya, and Prahlad sir for an excellent case, analyzing the case, and also Subrata madam, and Arun sir, and all the members, and also Madhusudan Karignuru sir, and Gaurav, Aditi, and Nidhi, and thanks to one and all. If I am missing any name, please excuse me. Thanks to one and all. So it is 100 more than crossed. The number is crossed more than 100. For the next presentation, it must cross 10 times. 1,000 is our target.
Yes. Yeah.
Number is not important. Quality is important, but we should reach to the maximum.
Yes.
So once again, we may need Prahlad sir's presence and guidance for this program. One more case you may have to present, sir, after 2-3 subjects. Please,
Sure.
we are asking your appointment from this platform only.
Yeah, anytime.
Thank you. Thank you, one and
We'll
all.
do a PG program also.
Sir, a few words before we close. I must say that clinical teaching is very precious, and we have been in a government college where we used to get a lot of chances to interact with teachers. And I think in that way, all students are getting a chance from IMA with renowned teachers like Prahlad sir to teach them clinical skills, whatever case discussions happen. So we will have more students watching these videos and learning later as well. So this is going to reach out to many, many more students. So I thank Narayan Murthy sir for actually taking up, even he is a chairman, he's not making members work, he's doing it himself. He has taken all the initiative and he has done. So thank you, sir.
Thank you, madam. Thank you for being with me.
Thank you, Prahlad sir.
Thank you. Thank you, Ananda. Thank you, John sir.
Thank you, sir.
Thank you.